So I'm going to go to biodesign. I'm going to quickly talk about the program itself. It's a program that started 20 years back, as I mentioned. Our vision is to be a global leader in advancing innovation, in technology innovation in healthcare, basically, and focus is really to improve lives everywhere. And we teach fellows, which is our flagship program. We bring these very experienced people together who've done remarkable things. We put them in teams of 4, just like what I'm doing with you guys. I'm putting you in teams of 4 to 6. They come in teams of 4, and they spend a year with us through the fellowship process. We also teach Stanford faculty. We have a faculty in training program. So we have taught hundreds of Stanford faculty through our training program, and they're all part of what we call BFF, Biodesign Faculty Fellowship. They are BFFs. They become very valuable when our fellows are working on stuff. And we also have global fellows and faculty. We had Stanford India Biodesign was our first global program. We had 4 fellows that came from India, got trained at Stanford, then went back and came up with remarkable innovations in India, and I'll show some of them. And some of them will actually speak in this program. Some, maybe a couple during module 1, but a lot of them will be mentors of yours in module 2. So that's my Guru Dakshina that they'll be giving here by participating in this program. We do have Stanford students. We have a number of courses that we teach. I teach 2 courses myself. And then we have researchers who we collaborate with and support. And then we also teach industry executives in this methodology. So it's a broad group of people that we train. At the very root of biodesign, as the design thinking correctly points out, is that it's not technology push. Don't come up with the technology and try to push it, try to shove it down somebody's throat. Can you guys give me an example of where technology push has not worked, where innovators have come up with technologies that haven't really taken in the marketplace? Any examples? Zune, anyone? You remember Microsoft Zune before iPod? That was a technology push. Any other examples? I would love to come on. You guys are engineers. You guys should come up with examples like crazy. Any examples where technology push has not worked? Google Plus, yes, absolutely. Yeah, ebooks haven't really taken off. Kindle has taken off to some extent, but they probably misread their the group, their stakeholders. I don't know market predictors, actually. That's a good example, interesting example. Okay, we'll be saving these chat transcripts, right, Harshita and Adesh? Because there are some interesting things that are going to come out here, I suspect, and I would love to be able to go back to that. Bone conduction earphones, that's a good example. It's a technology push, hasn't really taken off. Maybe there is a good science there, but maybe they have not done the design thinking enough. Maybe after you guys are done with the program, you guys can go back to them and say, I have just the framework for you guys to figure out what you should do with your technology. But when you start with the technology, you already start with a bias. What I'm going to ask you guys to do is put aside your technology biases. It doesn't matter what background. At Stanford, we have computer scientists who go into chemical engineering and try and learn that after they've identified the problem. So learning to cross disciplines is going to be really critical. Your groups are going to allow you to do that. Don't just rely upon your knowledge alone to solve a problem. First, understand the problem, and then bring everything you need to solve it. And by the way, just because you are a particular discipline doesn't mean you only have to apply that discipline. You're learning analytical skills. In engineering, you're not just learning computer science or electrical engineering or chemical engineering or whatever, or metallurgical engineering. You're also learning how to apply logic. And that's a much more powerful learning that you have than the engineering degree that you have. I think there's tremendous value in the deep knowledge of the fields that you're in, tremendous value. But you don't always have to rely only on that. You can apply logic. Like I know a number of you have worked on health technology solutions. That's not your background. Medical is not your background, yet you guys have worked on it. I'm a chemical engineer who is actually a professor in School of Medicine, right? So there's nothing that prevents you from being involved in problems that may require diverse skill sets. And your job is to bring those skills. So I think starting with technology, the problem is that you are approaching with very limited solution set, and you're not even understood the problem yet. How do you know that technology is not going to miss that problem? The problem is here, and technology is just sort of passing it by. How do you sort of find the problem and then find what kind of technology sets could address that? That's really what I'm pushing you guys to do. So GeoGlass. I don't know about GeoGlass yet. Hopefully, GeoGlass has some design thinkers within their initiative. So I don't know about Hyperloop. So the thing is, Hyperloop is a technology push to a certain extent, but there is an unmet need that Elon Musk actually identified, which is you need to move people very, very quickly. So hopefully the problem definition was, I've not looked into the way they define the problem, but that may be a good case study actually. So the goal is not to do technology push, but to do need pull. That's what I want you guys to focus on. Okay. By the way, there is some scribble on the screen, and I don't know how to erase that. So you guys, Harshita and Nadesh may have to figure out how to get that out. So if you have a single user, like an iPhone user, designing for that is relatively straightforward. But if your user is a system, healthcare system, how do you design? Which is where BioDesign actually looks at the patients, the physicians, the hospitals, the regulators, the payers, insurance companies, the stock market, the physician societies, the press, and of course, politicians, right? Policymakers. So all of them actually play a role in healthcare system and what solutions actually are needed for the problems. And that's why we came up with the BioDesign methodology that actually uses design thinking at its core, but structures it in this manner: identify, invent, implement. Identify is understand the unmet need. This is where your empathy and define comes in. So deep needs finding, which involves clinical immersion, for example, and then screening those. If you notice there are circles going around there, there's a lot of iteration that happens there, and we'll talk about that. Second part is invent. This is, you only go to the invent phase once you've finished your identification phase. If you've not finished that, you cannot move on to the solution phase. That we apply that regularly in the program. So in the invent phase, there's development of concepts and screening of those concepts. And some of you asked, how do you choose those concepts? We'll talk about that. And only after you're done with invention and you picked a particular concept, do you go on to implementation, which is a big, hairy stage. That's probably where you'll be spending most of your time, most of your money, most of your energy. But success of implement depends heavily on what you do in identify and invent. Even though in terms of amount of time, amount of resources that you invest, identify and invent is much smaller relatively. But the importance of that is supreme. You really need to get your identification and invention really, really right. If you get that right, your implementation is going to be much, much more. And tens of millions of dollars you'd raise to build that solution and to go to market with that are going to be worth it. And it's going to return an appropriate returns, basically. Okay. Okay. So I'm just going to go through specific aspects of it. First stage is needs finding. You start by identifying lots of needs, and you do that by putting yourselves in the shoes of the user, and we're going to teach that in this program. And once you've done that, go through a series of filters to find the need that really work. And that's the second stage I'll talk about. But before I go there, there's something that you're going to learn in this program called structuring a need statement. Need statement is a very, you guys are engineers, so you'll love this. It's a very structured way of defining or stating what the problem that you're trying to solve. There are three parts to it. Number one, what is the problem you're trying to solve? Number two, for whom are you trying to solve that problem? And number three, what outcome do you want as a result of it? So in case of Zune, Microsoft could have said a way to bring music portability to all young professionals so that they have smooth listening experience while they are going to work. I'm just making it up. If they had defined it in that way, they would have designed Zune in a very specific way. Okay. What did Steve Jobs do? He didn't have a need statement, but he had a need statement in his mind. And his need statement, what do you think his need statement was? Can somebody take a crack at when he came up with iPod, not iPhone. iPhone came much later. iPod was the original one. This was a music player, simple music player with a very, very unique kind of interface. And some of you probably don't remember that iPod, but if you do, can you tell me what problem was he trying to solve, in which population, and with what outcome? There you go. Yeah. So his thing was he wanted the outcome he wanted was 1,000 songs in the pocket. But which population was he going after? So that's the outcome. What you said about 1,000 songs in your pocket is 1,000 songs in your pocket is the outcome. Which population was he serving? Which population did he have in mind? Young adults. That's exactly right. Young adults and young professionals, basically. He was going after them. He was going after their experience. And what was the problem he was trying to solve for them? What problem was he solving? Ease of listening and experience of listening. If you notice, if you listen to any of his presentations, he talks about the experience of listening. He wanted the experience of listening to be supreme. So his problem he was trying to solve was the experience in listening to music was suboptimal. That's the problem he was trying to solve. So he had a problem in mind. He had a population that he wanted to go after, and he had an outcome that he wanted to end up with. And if you notice, he actually drove his team crazy by saying, "No, I need those 1,000 songs in the pocket. It had to be in the pocket. It had to be 1,000." Like there's a whole case study around Gorilla Glass that he ended up using on his iPhones later on. The way he pushed his technology team to dig up this technology. It existed, nobody was using it. So here was the case where he knew what the problem he was trying to solve and how he was going to try to solve it, and that's when he brought technology. He didn't start with the technology. He did not start with the technology. He started with the problem and the outcome that he wanted in a particular population. That's a good example, actually. Exactly. I think user experience for listening to music and portability. So here's an example of a need statement that came out from BioDesign itself. This is 3 or 5 years back, actually, and this was focused on melanoma. These fellows actually spent a lot of time in dermatology, and they realized some significant problems. They realized that a lot of people were dying of melanoma. It's actually a life-threatening disease, and it starts with something very simple like a lesion, skin lesion, or something that happens on your skin. But what happens is a lot of these patients go to a primary care physician who doesn't really understand it, or just apply an eczema cream, apply some sort of ointment that basically addresses that, and it doesn't. Most of the times it doesn't, right? But it looks very similar to regular stuff that does respond to these eczema creams. So a lot of these patients never move on to either a dermatologist, or if they go to a dermatologist, they rarely move on to a cancer specialist, an oncologist. It's only when they go to oncologist are they discovered with this melanoma. By the time it's late, it may be third stage, and you may be at risk of dying. So what this team realized is that there was a need to catch these people early on. So their need statement was a way to perform point of care testing in patients. So the problem that they were trying to solve was the point of care testing. Point of care meaning when they see the doctor for the first time for their problem. That's point of care. So perform point of care right then and there, so that otherwise you could take for biopsy, and then the results come back a week later. Patients have already gone back home, right? So, and by the way, this kind of problem becomes even more significant when you're talking about rural areas in India who come 50, 100 kilometers to a city for a major problem, and then they go home and then they're lost to follow up. So point of care testing was the problem they were trying to solve. And which population? Patients with skin lesions. They focus on patients with skin lesions, not broader patients, not patients who have gone through a bunch of screening already. Any patients who had skin lesions for them. And what were they trying to, the outcome that they were trying to focus on? Accurate, inexpensive diagnosis, not screening, diagnosis of malignant melanoma by a dermatologist. This is incredibly specific statement. Okay, what the statement does is it allows the team to then go on and come up with solutions that focuses on dermatologists, because a dermatologist training is different from an oncologist training, right? A diagnostic technology is different from a screening technology. Diagnostic has to be much more precise. Okay, and then it had to be accurate at the same time inexpensive. I think there is somebody's unmuted. You may want to mute yourself because I'm hearing some sound in the back. So this is how you structure your need statement, so that You are very precise about what you're writing code. You may not get it perfect for the first time. You just get better and better. There's a team that I'm mentoring right now, young team, that's working on hearing loss, seniors living with hearing loss. And they found an unmet need. So they found a series of unmet needs, and then they prioritize one particular one. And their unmet need has evolved so much over the last 3 months that they've been working on it. They're going back to the stakeholders and they're iterating it. They're putting a lot of hard work into it now. I know the solution they're going to come up with is going to be brilliant because the need is so well defined. Okay, you already start to see what the solution, how the solution could be very powerful. This is one such need statement. These guys actually came up with a solution that's actually now being deployed commercially. The most important thing is when you're doing the need statements, when you're defining the need statements after the immersion, clinical immersion, no solutions are allowed. You should not be thinking about solutions. We as engineers tend to rush to solutions. Okay, we just want to jump right in and use our brilliant engineering skills to solve the problem. Hold off on that when you're doing the needs finding. Okay, and once you've done that, once you've created these hundreds of need statements based on your immersion, you screen those needs based on certain criteria, and the criteria can be the prevalence of the disease, incidence rates, are there existing solutions, who are the key stakeholders, what is the market size. There are a number of different screening parameters which we'll talk about later on. Okay, and once you've picked the need that's most important to you, you got to do this. This is really, really important. You have to figure out what is absolute must-have in the solution. Okay, there's a team, and I'm wanting the team because they're one of my favorite teams in India. They came up with a really brilliant solution for monitoring neonates. Okay, their first concept had 18 features. Brilliant technical solution. 18 features. It was to track symptoms, different parameters with a newborn in these neonate wards, where a nurse is monitoring those 20 kids. In the US, there's one nurse for 2 kids, 2 neonates. In India, there's 20 kids in the ward that a nurse is tracking, and she cannot pay attention to everybody. So they thought, if we have a tool that monitors all of these things, a nurse doesn't have to pay attention to all of these, and there could be alarms. But what is the problem? If there's the slightest parameter off in a particular baby, alarm will go off. And now you have 20 babies whose alarms are going off, and there's only one nurse. What did they do? They did not focus on what was must have, what was nice to have. They dug into the need further, and they realized the only 2 most important needs that these nurses had, most important ones. All of the other needs too. One was temperature, and one was heartbeat. Those were the 2 that the nurse really wanted to know. Those were the most important parameters. There were other things that she would care about, but if there was a catastrophic situation where the heartbeat was, there was an issue with that, or there was an issue with the temperature was shooting up, nurse needed to know, and they basically redesigned their solution, and now that actually is a far better solution for these nurses, because it was targeted at nurses, because they're the ones who take care of these neonates. So must-have criteria versus nice to have. Okay. Once you've done that, once you have, actually, there's a very interesting question. How to come up with a prototype which has dynamic needs if the needs keep changing with time. So, if a need keeps changing with time for a specific patient or specific user, now, for example, this phone meets my needs. Apple still keeps coming up with new versions of these. My needs aren't necessarily changing, to be honest with you. So my needs are constant. So this is not a good example where you're having to do that. But on the other hand, if a disease is constantly progressing for a patient, your solution that you developed was for a specific set of patients, like the previous need statement that we had about skin lesions. These were patients who had skin lesions that had not been diagnosed. But that patient's needs are going to change once the lesion has been diagnosed, right? So the solutions for that are going to be different. So you have solved one particular problem that you felt was the most important problem in the society. As the needs change for that particular patient, and you see there are enough number of patients or enough number of people who have that need, then you need to come up with another solution. But I think you really need to pick a need that is well articulated and that is at that sort of framing, that window is static enough for you to solve it. Do you have an example of the needs, changing needs that you're talking about, Nirmal? Yeah, I think there's some interesting examples for gynecologists and oral cancers, which I agree with. Actually, those are all very very important unmet needs. Absolutely. Um, so, Nirmal, if you have any examples of any specific example, I think healthcare is a broad field, right? Any specific example where the needs are changing. In case of COVID-19, for example, patients' needs are changing rapidly. So, patients who have severe COVID-19 situation, where they're not able to breathe, their lungs are not able to cope up with the respiratory distress that they are in. So a lot of these patients, the serious patients, need to be put on mechanical ventilation, where the tube goes down the throat and mechanically you're pumping air, right? Many of these patients have evolving needs because there's cytokine storm going on, lots of things going on actually. There may be blood clotting going on. That's an example of fast changing needs actually, right? So how do you have a ventilator that addresses a patient? So if you had a ventilator that was designed specifically for COVID-19 patient, likelihood of that looking different or having a different software or different programming parameters or different protocols is high compared to a traditional ventilator, like a traditional mechanical ventilation for trauma patients. So trauma patients, when they come in, they are in serious pain and their body isn't quite capable of doing things lot on its own. And I just went through, a family member just recently went through it, so I saw this up close and personal. There, the ventilation needs are much more defined. This patient is going to be in the ICU for a week, 2 weeks, and it's going to be mostly stationary. His situation is not going to get dramatically worse or better. So the needs for those 2 weeks are going to be somewhat constant. There may be some need for a different protocol, ARDS versus some other protocol, you do switch those, but they are well-defined 2 or 3 protocols for that machine that you can use. Same equipment, same everything. In case of COVID-19 patient, things are changing very, very rapidly. Okay, so how ventilator is used for a COVID-19 patient could be quite different. So here, the solution, maybe it's the same mechanical system, physical system, but it's a programming that might need to change, or there may need to be a tweak in the tube that goes in. Okay, or there may be an additional drug infusion that happens along with. So you have to pay attention to the unmet need and the evolving nature of unmet need during the window of solution that you're trying to provide. Okay, so that's part of unmet needs finding. So you can actually come up with a solution that addresses rapidly evolving needs in a given time setting. Okay. Yeah, I'm seeing some comments about interesting unmet needs. Absolutely. By the way, all of these are good starting points, but I will challenge you on each of these because I've been advising a lot of innovators during COVID-19 who are working on vaccines, diagnostics, PPEs, ventilators. So every one of these, you need to go much, much deeper to truly identify. And in fact, part of the scope that we're going to focus on this program next 4 weeks is unmet needs during COVID-19. Okay. Okay, so I'm going to finish this, and I have a workshop that I do want to do with you guys. So I need to go through this rather quickly. So concept generation is the next stage where you come up with lots of ideas, lots and lots of concepts, crazy ones, and only when you feel that you're really exhausted the range of concepts do you come to concept screening. And this is where you go through filters using a number of these different kinds of filters. And we'll walk through that in the program. And once you've done screening, it doesn't stop. This whole thing about prototyping and testing, it comes into play. You got to keep on iterating on it. Okay, so initial concept selection, you do a first stage of filtration, you do more concept exploration and testing, and then you do final concept selection. Once you've done the final concept selection, only then you go to implementation phase, which is a big long phase, and that's not going to be part of the focus for the module 1. Okay, so I'm going to skip this, but there is. And by the way, ebiodesign.org, anybody who's interested in biodesign resources, there's tons of videos. You see some of our India fellows are featured there. On the left, Pranav Chopra is one example, but there are a number of them. ebiodesign.org, it's free, actually. And if anybody wants to go deeper, there's a big fat book, and I'll show you that book next time. I have it in another room. It's like several hundred pages, and it's a Bible of medical device innovation. Okay, I'm going to quickly talk about immersion. Our fellows in India have done clinical immersion in really wide range of settings, and they've ridden in ambulances, they've gone to these remote primary care centers, and to the hospitals when they do the immersion. Unfortunately, because it's a short program, and unfortunately we have a shutdown because of COVID-19, you guys won't be doing that. I'll give an example of a really brilliant solution that came up. Here's an example of a newborn resuscitation. Newborns, when they're, especially if they're preemies, they're underweight and their lungs don't function well, so they can't breathe very well. So there's something called resuscitation resuscitator, a bag and mask, that what you see on the left side. There's a mask is placed on the baby, and a bag, ambu bag, that actually is used to pump air into the baby. And its forced ventilation allows forced sort of air allows the lungs to expand and allow the baby to breathe. If we don't do that in the first few minutes of baby being born, baby can die. Problem in India is that a lot of nurses are not well trained on this, and it requires multiple people. And as I mentioned earlier, most nurses, most hospitals, most clinics are poorly staffed. So Dr. Avijit Bansal, who is one of my fellows, actually came up with this brilliant idea, defined the unmet need, came up with a solution that actually uses foot pedal operated resuscitator, which delivers a constant volume of air, takes away the need for hand pumping, and frees up the hands to put appropriate seal of the mask on the baby, which was a major unmet need. And the second thing was to be able to do that hand for other activities that may be needed during resuscitation. Brilliant solutions now in 12 countries and saving lives.